the optimal dosing of 13 to 15 milligrams per kilo. So if your body weight goes up by 33% and you have the same dose of urso, you might be underdosed. So it's always wise to check out your actual dosing against your current weight. Because with weight gain, we tend to have, in the United States, about 10 to 20 pound increase per decade, 1 to 2 pounds per year. So that can make a difference. Now, the other thing is, if your alk phos is now going up, it has been normal, and you've got the right dose, remember, bone and gut are two other sources of alkaline phosphatase. That's when I would look at the fractionation and see if you've kept control. And then it says, it appears that OCA may be helping many of us, PBC, what are the stages, who participated in the clinical trials of the new drug. Everybody through cirrhosis. There were cirrhotics in the trial. And at what stage are you presenting, let's see, and at what stage are those who are presenting in our site? In our site, as an investigative site, where we're recruiting people with more advanced disease because we're recruiting for that cobalt study. That's the study side of it. For our liver center, we see patients with all stages of disease and help with diagnostic dilemmas that might occur. Okay. One more? Okay. Okay. Does a positive AMA always indicate PBC? What a terrific question. We would have said 5 to 8 years ago that if you have a positive AMA, and it is verified that it wasn't a laboratory error, that you either have active disease, and if we did the other tests, you'd have an elevated GGT and an alk phos, et cetera, or you are preclinical and pre-biochemical, and with time, will develop that. And we had great evidence from Europe back in the 1980s that that would be true. Now, especially using our molecular-based testing, which is different than looking at cut sections of tissue and looking at mitochondria under the microscope. This is done on an automated test in a little plastic well. We are finding people who have verified AMA whom we believe do not have and are not developing PBC. We have a series that we're 5 years into when we first reported this, and we did this work in collaboration with Eric Gershwin and several other experts. And we have had excellent molecular identification that the AMA is truly AMA. But we were finding it in people with non-alcoholic fatty liver disease, a few patients with chronic hepatitis C, and a few patients who appeared to have minimal inflammation, none of whom had any criteria on biopsy or laboratory testing to have PBC. We have now followed the majority of those patients for 5 years, and we still have no evidence that they are moving their alkaline phosphatase up, moving their GGT up. There's nothing like what was reported in the 1980s. So this is a great question. We don't know what that means. But remember, Eric was telling you about environment and genetics. If the environment is very conducive to stimulate this process, there may be different gradations of what the consequence of that process is. Meaning that somebody might get AMA, but they may not have it in a way that translates to the T cells destroying bile ducts. In other words, they could have the marker of the disease without the disease because the immune system is like dominoes. You know, they flip over and they keep knocking one another down in different pathways. This may be telling us that AMA doesn't always follow a pure pathway to disease.
I have the unfortunate job, once again, as I did with Eric yesterday, of saying, you're done.
Yeah.
I hate to do it. We could have him talk all day, but we have to keep on schedule. Those of you who didn't get your questions answered, as he said, he'll be here, and you can talk to him privately. So, John, it's great. We appreciate your being here. We have this small token of our appreciation, and Lenny sent you these Texas pecans, which I'm sure you know all about, and we'll love to have them. Okay?
Well, thank you very much,
Carol. Thank you very much, John.
Before we introduce our next speaker, I do need to do a little housekeeping. We have two requests. Number one, please silence your phones. Put them on vibrate. It's been a little difficult with some of the phone calls coming in. And number two, several of us were talking at dinner last night, and we came up with many off-the-wall cures for some symptoms. You know, you've heard for years that preparation H gets rid of circles under your eyes. Okay? If anyone else has any fun little tips of what may have worked for you to help with itching or to help with dry mouth that may be just a little off the wall, write it down on a piece of paper, and let's leave it back at the registration desk back there, and we have a few really fun ideas to share with you later in the day. We're also hoping later in the day to try and get a group picture of all of us participating in support of the American Liver Foundation. They are doing a campaign right now where you suck the lemon. Carol will give us just a little bit more information on that. At about 1:10, right after lunch, before we start our afternoon presentations, we'd like to ask those of you who do want to participate, we'll have lemon wedges for everybody. We can get a group picture posted on our Facebook page, link it to the ALF, and again, it's showing a support for liver disease. It is my pleasure now. Yesterday I had the opportunity to introduce the man that talks me off the wall when I get a little crazed with my liver issues. And this morning it is my pleasure to introduce the driver of my bus. And when I say the driver of my bus, it is Dr. Jennifer Pate. She obtained her BA in psychology with a minor emphasis in philosophy in May of 1992. She graduated magna cum laude from the University of St. Thomas in Houston, and then was awarded her MD from UT Medical Branch, Galveston in October of 2000. She was a resident in general psychiatry from January 2001 to December 2004 in the Menninger Department of Psychiatry and Behavioral Sciences with Baylor College of Medicine in Houston. She is currently Chief of Psychiatry at CHI St. Luke's Hospital, a clinical assistant professor of the Department of Psychiatry and Behavioral Sciences with the University of Texas Medical Branch, and provides the liver transplant and family education class at St. Luke's Hospital in Houston. This is all in addition to her private practice. One of her specialties and one of the things that has been so wonderful to me is I fought the idea of going to see a psychiatrist. Dr. Ancomase argued with me. He says, go see Jennifer. I said, I'm not crazy. He said, go see Jennifer. I said, I'm still not crazy. Last week I apologized to him and said, I should have been seeing her all along. This is the woman that will help us all learn how to cope with chronic illness, how to not let PBC define us, but how we will all live with the disease, get stronger, and it is my pleasure to introduce my bus driver, Jennifer Pate.
Wow, I didn't expect that introduction. That is actually really quite nice, and I have to say I'm proud to be Tina's bus driver. All right, so you've heard a whole lot about your liver and what it's doing with PBC. So what I'm going to talk about is how to live with your liver. So what I'm going to talk about today is how to cope with both PBC and other chronic illnesses. So let's just jump right in and get started. And also some of the things that Tina talked about in terms of the most bothersome symptoms in PBC and related conditions, including fatigue and itching and dry mouth, I'll talk a little bit about. So I'll give you guys some ideas about that too, because that is really what I spend my day doing. I would say about 98% of my practice involves taking care of patients with liver disease. I see about 2% of other stuff, but really my first love is taking care of patients with liver disease. So All right, so chronic illness affects probably everybody in this room to one degree or another. 1 of every 2 Americans has a chronic illness, or 133 million people in the U.S. And as I'm sure you've heard many, many times over the yesterday and today, 19 to 402 cases of PBC occur per 1 million people. So in addition to the physical challenges of the illness, really managing the psychological issues are actually very problematic and take their toll as well. All right, so let's talk about some of the psychological challenges of PBC. So first of all, it can be difficult to understand, well, what are those bile ducts and what are they doing and what are those enzymes and where do they come from and what are these medicines and what does all this mean? It can be actually quite a challenge to understand. So as all of you know firsthand, whenever you talk to a friend or a coworker and say, hey, I have PBC, or I have a liver disease, everybody thinks you drink too much. Oh, well, maybe you need to quit drinking. Okay, great. That's helpful. So the other thing, too, is, even though Dr. Vierling and I are really good at what we do, we can't actually see your liver and know what it's doing. So you have an invisible illness. There's no, equivalent to like a glucometer where you can go stick your finger and, do a test and see how your liver's doing that day. It doesn't work like that. So the challenge of having an invisible illness. Whenever you have a significant diagnosis of an illness like PBC, it also changes your identity. Who am I now that I have this illness? What does all this mean? How much is this going to impact my life? So there's a lot of uncertainty about the future, although like Dr. Vierling said, there's a whole lot less uncertainty than there used to be. So one of the unfortunate things about PBC and autoimmune liver diseases is that your chances of developing another illness over time are actually fairly significant. So about 1/3 of PBC patients go on to develop an autoimmune disease of another type, whether it's thyroid disease or some other autoimmune disease. One of the things I hear about often as one of the big challenges that my patients with significant fatigue in particular experience is how difficult it is to repeatedly disappoint themselves and other people. You expect to go out to dinner with friends on Saturday night and, early afternoon you've just hit a wall and you just realize, okay, dinner's just never going to happen. So that can also be really, difficult, and it's hard to repeatedly disappoint people over time. The symptoms such as itching and fatigue do not correspond to how severe your liver disease is. So I have patients with very advanced disease who are, active on the liver transplant list who may not feel all that tired or may not have all that much itching, whereas I may have a patient with very mild disease on their liver biopsy who's really quite impaired by the fatigue or the itching. So that's one of the frustrating things too, is you can't tell, oh, okay, I'm itching a lot more, that means my disease is worse. It's not a linear correlation like that. All right, so let's talk about the reaction to the diagnosis, particularly if you were just recently diagnosed. I think there's a certain amount of shock. By definition, people have this disease through no fault of their own, meaning you didn't drink, you didn't use IV drugs, and so it's not that you can identify any kind of behavior that led to this. This is an autoimmune disease, so a lot of people are told, hey, you have this autoimmune liver disease, and a lot of times patients are really quite shocked. Since we can't see it, and you can't quantify it every day, a lot of times it's hard to believe that you really have it. Well, you can't see it, so therefore maybe it's not really there. Or a lot of patients try to pretend that it's not. Sadness, or, what I see a lot is people really catastrophizing, particularly when it was called primary biliary cirrhosis. Oh my God, cirrhosis, that means I'm going to die. Well, even if you have cirrhosis, that doesn't mean you're going to die. That's a whole different topic and reason for education. But a lot of people freak out and think, that this is the end of the world. And actually, especially with the new therapies, that's not the case at all. Again, I mentioned denial, the ability to kind of bury your head in the sand and pretend that this isn't really an issue. Sometimes, particularly for my patients who are very symptomatic with fatigue, okay, it helps to have an answer that I'm not crazy, that there's a medical explanation for the fatigue. All right, so let's talk about that. That's one of the most disabling symptoms. That's a reason why people are referred to me. That's actually one of the things I'm really good at treating. It's very rewarding for me to treat because I can actually say that in every case of PBC in my practice, I've gotten it better. So it's very difficult to talk to your doctors about fatigue because I think doctors, family members, and friends kind of, maybe they don't say this, but you kind of get the sense that they're kind of kicking back and looking at you like, really? How bad can it be? You look pretty good, you're going to work, and you think, oh my God, the doctor's just sitting there thinking, oh my God, she's just so whiny. And the reality is they probably don't really get it, but I can say that I do. So the other thing too, and I've mentioned this before, but I think it's important to remember, is worse fatigue does not mean worse liver disease. Again, I gave the example before, and I won't go over that again. One of the frustrating things for the few patients that I do have who have received a liver transplant is the fatigue doesn't always improve after transplant. And that's particularly shocking for my transplant patients because they think, oh, I'm finally going to have a better energy level. Well, you might from your immunosuppression that we put you on first post-transplant, but as that's tapered and you're sort of restored to your new baseline, the fatigue's not always better. But again, I've also been 100% successful in getting it better post-transplant. So the good news is we can do stuff to help. The other thing too, and this is something that doctors consistently get wrong. If the doctor first understands that you really are fatigued, then they often automatically assume that fatigue is depression. Okay, you're complaining of being so tired, therefore you are depressed. And actually the two are not the same thing. You may be fatigued and be depressed, but just because you're fatigued does not mean you're depressed. And unfortunately, a lot of doctors just don't understand that. There are symptomatic treatments available. Let's talk about that. So let's say you are both fatigued and depressed, okay? And again, fatigue does not equal depression, but let's just say you have both. So one of the best antidepressants for that is actually Wellbutrin, and the newest form of that is Wellbutrin XL. That is our most activating antidepressant on the market. I like to refer to it as my couch potato antidepressant. So for people who are depressed, laying around, sitting on the couch, have no get up and go, have no motivation, no interest in anything, if I'm looking at my menu of antidepressants that are safe in liver disease, which the vast majority of antidepressants on the market can be used in different ways in patients with liver disease. Over here is my most activating antidepressant, which is Wellbutrin XL, and for a patient with PBC who's also fatigued, it may be my antidepressant of choice. Over things like Lexapro and Celexa and Prozac and Zoloft, Wellbutrin XL has a little bit more spunk and get up and go to it. So If that's an issue for you, you might want to talk to your doctor about Wellbutrin XL. Again, I have no financial conflicts of interest. I'm not supporting any drug. I'm not suggesting you should be on any particular drug. I'm just talking about what works. All right, so probably one of my most common treatments for fatigue in PBC that is usually quite successful is Nuvigil or Provigil. Nuvigil is the newer, better form of the medicine that just in June of 2016, so the month we're in, it just went generic. So that means it's going to be much more available to patients, and insurance companies are going to cover it better since it's a generic, and it's likely going to be a little bit more affordable. It's still pretty pricey, but there are, for the branded version of it, there are good copay cards available. The other thing, too, that I use quite often, primarily in more advanced disease, but I have a really low threshold for using it in anybody with PBC, are stimulants such as those you'd use to treat ADHD. So that means things like Ritalin, Vyvanse. Those have an immediate effect. You take the dose early this morning, you're going to feel a difference today. And the nice thing, particularly for people with advanced disease, is Ritalin is so short-acting that even with a liver that's not functioning up to speed, it's still going to be cleared by the time you go to bed tonight. So it's not likely to make you more, give you more trouble sleeping. Those are some great options. For those of you with more advanced disease who may be on a beta blocker for portal hypertension, those of you who have been told you have esophageal varices, you may be on drugs such as Nadolol or Propranolol. One of the things that I do, I even had one patient that I saw, and all I did was I switched the beta blocker to bedtime. It is incredibly helpful to switch it to bedtime to help with daytime fatigue. Just that simple change can make a big difference. All right, so let's talk about some real-world pointers for fatigue other than medications. So it's sort of a no-brainer, but you ought to plan activities for the best part of the day. Think about, okay, well, how do I function best? Are you a morning person? So when you're talking about getting together with friends, plan a breakfast or plan a brunch. Don't plan a late dinner because it's just going to increase the chances that you're not going to feel up to doing it. So plan activities for your best part of the day. This is a really hard one, but limit napping to avoid disrupting your sleep. Or if you're going to nap, I would say nap for about an hour or less, because otherwise you're going to get into trouble where it's difficult to sleep that night. Optimize sleep hygiene. I talk about this a lot with patients. Everybody thinks that going to bed with the TV on helps them. It absolutely does not. Research shows that the little tiny lights in a TV stimulate your brain to stay awake. So that's going to get in the way of sleeping. I'll talk about itching in a minute, but one of the things, too, that's important, especially during the Houston summers, is make sure that you're keeping your room cool. Go to bed with it dark. If you have a lot of trouble with insomnia, do something non-electronic, such as reading a paper book. Again, you want to avoid computerized devices because the little tiny lights will keep your brain awake. Avoid supplements and energy drinks, as Dr. Vierling can attest to. Several times a year, we have somebody come in just who was previously healthy, come in full-blown liver failure. We are all emergently working to try to get the patient listed for transplant because they used some supplements. And so patients ask me all the time, what kind of liver cleaner can I use? There is no safe way to clean your liver. So I recommend avoiding any kind of supplement or energy drink, particularly those that are going to help with weight loss or energy. they are really very dangerous. And as most of you know, supplements are not under the jurisdiction of the FDA. So I could say that my bottle of water is a liver cleaner. You guys would believe it. And the FDA does not police this, so I'm allowed to say this is a liver cleaner. So just stay away from all of that, especially since you have a liver disease. This is a hard one, but do some low-impact exercise at least several times a week. It's getting to be very hot in Houston right now. One of the things I recommend regularly is that you should go walk a mall. It's an air-conditioned place where you can safely walk. It's just getting way too hot to walk outside, but do some low-impact exercise several times a week. That will also actually, ironically, help the fatigue. If you're super, super, super tired, limit your time in bed because you'll likely end up deconditioned, and that's really a big mountain to overcome. All right, so let's talk about itching in PBC. I actually had the wonderful opportunity to go to New York to meet with Nora Bergaza, and I actually learned quite a bit from her, and I used what I learned several times a week. So as you guys know, the medical term for itching is pruritus. Itching's much easier for me to say, so I'm going to call it itching. So about 80% of patients with PBC experience itching. It is worse in warm weather. It is also worse after a warm shower. So one of the things I do is I talk to patients about, well, what time of day do you shower? And if patients say I shower at night and their itching is really bad, I'll say switch your shower to the morning, because that way the itching won't keep you up at night, because you don't want to trigger that whole sequence of events of showering at night and end up staying up all night itching. Staying up all night is bad enough by itself. It also tends to be worse at night apart from showering at night. So you've got a couple of different factors to work with, so you want to do everything you can to help it at night. That's also why you want to sleep in a cooler room. So all you guys in the room who have a wife that's itching, just, bundle up in a blanket. She's going to want it cold. Topical treatments are actually, I said, not always helpful. I would say they are rarely helpful. My PBC patients often go to see a dermatologist and they're told to use a steroid cream. A steroid cream won't help this at all. It's not a topical skin problem. As John mentioned in his talk, it's a problem with bile acids and endogenous opiates and a whole lot of biochemical substances you guys don't care about. But it is not that you got poison ivy and you're itching. So some of the best treatments that I have found are the antidepressant Zoloft and the medications Colestipol or cholestyramine. So Colestipol and cholestyramine are fairly similar. The difference being Colestipol is a pill. Cholestyramine is a gritty orange-flavored powder that doesn't dissolve in the liquid very well. So my patients tell me it's like drinking ground up sandpaper. I don't know about you. I'd rather take a pill than drink sandpaper. So there's a huge dose range on the Colestipol, but typically a very low dose helps my patients. I would say there are two big drawbacks. One is Colestipol is a big pill, but you can split it in half. The other thing too is it needs to be carefully timed with other medicines so it does not inactivate your medicines. You can certainly work with your pharmacist to figure out how to time things. This is particularly challenging for my patients who are on meds 3 or 4 times a day, but I can say the vast majority of my patients improve on Colestipol. I do not use the opiate antagonists much because they have some liver toxicity of their own, and I don't use rifampin either. just because I'm a little scared of the liver toxicity, and I don't want some patient going back to the liver team and being like, yeah, Dr. Pate told me to take this stuff, and the team's like, that's just great, and that I caused the patient some further damage. So these things I'm talking about almost always work. I can't think of a patient I've had that has not gotten better from these. The other thing, too, that Dr. Bergasa taught me about are light boxes. It has to be 10,000 lux. That's a strength of a light box. These are available at Amazon. They're actually not that expensive and can actually be quite helpful. All right, so let's talk a little bit about the question of, am I sick, tired, depressed, anxious, or all of the above? Okay, so we pretty much covered sick, we covered tired, let's cover depressed and anxious. All right, so I'll ask a lot of my patients, so are you feeling depressed? And most of them understand what I mean by that, but I have a few patients who are like, I don't know what that means. So depressed means you're feeling sad or down most of the time. By definition, it's supposed to be for 2 weeks, but I don't really stick to the definition that much. It's more an overall picture. Have you lost interest in things you're doing? Or do you find you aren't going to do the things that you usually like to do as often? Have you had a significant weight loss or a weight gain? And I would say that is not due to a medical reason. Okay, we can be put on medicines, and those may cause significant weight gain. That is not an indication that you're depressed. You're having a medication side effect. You may have sleep disturbance, sleeping too much, too little, psychomotor agitation or retardation. That means you're moving a whole lot more or a whole lot less than you normally would. Fatigue, this is not a good symptom for you guys because fatigue and PBC are sort of a deal. So if somebody's fatigued, I usually attribute it more to the PBC than to the fact that they're depressed unless they're clearly depressed. Feelings of worthlessness or guilt or feeling like I'm too much of a burden on my family, poor concentration or indecisiveness, thoughts about death, particularly would I be better off if I was dead? Maybe my family would be better off if I was dead. If you start thinking maybe I should kill myself and here are the ways I should kill myself, okay, that's a psychiatric emergency and you need to go to the ER. So in one study of patients with PBC, 24% of patients reported symptoms of depression. So there is some significant overlap. And the good news is it's very treatable. All right, so challenges to the depression diagnosis. A lot of doctors think that it's expected that a patient is depressed if they have a serious illness. I see this all the time. Well, I see lots of patients who are actively dying or have horrific medical situations who are not depressed.